Welcome, everybody, to Vircho's Social Impact Series. I am Ashley Perry from Vircho, and I'm joined today by Laurie Stradley from Impact Health in North Carolina. So, first of all, Laurie, welcome. Thank you for making the time to talk this morning.
Thanks for having me. I love to talk about this work.
Laurie, you were recently featured on the Bright Spots in Healthcare podcast with one of your colleagues from Healy, another social care network hub in New York, and with Evan Jones from Vircho. And it was such a great conversation. Really enjoyed it, and we heard such great feedback from folks who listened to it. And a lot of them were interested to hear more about some of the topics that you raised as part of that conversation. So we want to cover that and also give you an opportunity to share more about the work that you're doing at Impact Health in North Carolina. So thank you for making the time and looking forward to diving right in.
Excellent.
Um, as we get started, I wanted to just take a little bit of a step back and talk about the concept of social care hubs. It's obviously something that you are incredibly familiar with, but it is new for some people in some markets that haven't made as much progress as you have in North Carolina. So I was hoping you could start by talking a little bit more about how you view social care hubs and how they serve as what you referred to as the connected tissue in this space.
We have the opportunity, I think, in most of our communities to seek out support in social services, things like housing, food, and transportation. But in most communities, that means that if I'm struggling, I've got to find the resource and make the call, regardless of what else is happening in my life. And so over the last many years, it's been a growing movement. There's been this understanding that we need to better coordinate social care services for our community so that folks actually can get their feet under them and start to thrive. When a family's in crisis, it can be a full-time job just to piece together all of the things that you may need just to get by, let alone to start to look forward and plan your family's future. And so the social care hub model allows two things. One is to bring together all of these agencies that are supporting the community, they're mission driven, but they're often competing for the same dollars. And so they're, instead of coordinating and collaborating in order to really help the community, they're having to fight tooth and nail for the dollars that they need to deliver these services. And then they aren't always getting to some of the folks who have the greatest need and are seeing the greatest impact for lack of access. Then the next player that's come into this piece is our healthcare system. In the US, we pay the highest dollar in healthcare for some of the lowest or worst outcomes related to health. And part of that is because the US doesn't invest in social care in the same way that other nations do, in coupling both the health that we traditionally think of, going to the doctor, seeing a specialist, getting into that asthma person to make sure that you're getting your condition under control. Um, but coupling that with clean air to breathe in your home, healthy and nutritious food access, safe place to lay your head at night. So when you bring those two things together, you really need a group like a social care hub to help coordinate those two worlds of social care and social services with clinical care and clinical services. And if you do that well as a social care hub, everybody can stay operating in the area that they are the most expert at completing. So we don't want our community-based organizations to have to learn an entire new language, an entire new world to be able to deliver health services and get funded for it. We don't want our clinicians to have to spend more time navigating the social care system and not be able to see as many patients. So developing the social care hub at the center means that we can live in both of those worlds and make it possible for our healthcare providers to see the impact of social health, for our social care providers to get to the folks who need it most, for the funds to flow between all of those agencies and coordination and collaboration, but ultimately for that individual to get the resources they need without making it their full-time job.
Mhm. That's so important, and it's critically missing in far too many communities. A key piece of that, I imagine, is the integration work. And so would love to hear a little bit about what integration looks like when it really
Yeah.
works and the lessons that you've learned at Impact Health about how you do that effectively when you're working with so many different organizations, providers across that social care and clinical care ecosystem.
This is one of those where I really feel like you have to start with the end purpose in mind. So what's the intention of integration? What are we trying to do? And what our sort of leading, our North Star is to think about the member who has some sort of chronic condition or illness, and they don't have all the care and resources that they need to be well, to be healthy, to be able to live up to their full potential and do the things that bring them joy, dance with their daughter at her wedding or hold their child in their lap. Those things can be out of reach for some of our community members who don't have the full spectrum of care that they need. And so if you think about that member experience as the North Star, then the integration starts to become easier to imagine. And the way that the Healthy Opportunities Project or pilot has approached that in North Carolina is to put a care manager at the hub, at the center of that member experience. So that person has access to data about an individual's healthcare, chronic conditions, and just general health status. And they have access to clinicians for referral, and they have access to social care for referral to make sure that that member gets the full spectrum of care, what we call whole person and person-centered care. So if you imagine someone who has a new diabetes diagnosis and they get a call from their care manager to help make a plan, and that plan may include things like nutrition education, understanding the medications that they're going to need to start taking and using and how that impacts the way that they can and should be eating. What does physical activity look like when you're navigating diabetes? But at the base of that is, do you have access to the foods that you need in order to get your diabetes managed and under control? Because we know that some individuals live in food deserts. Sometimes it's a cost that keeps them from accessing the right foods. But with that care manager at the center, they're able to communicate in all directions and truly have a whole person-centered approach to a care management plan. And what that also means is that we need to get the clinicians more involved in what is happening on the social care side. We've had a lot of feedback, and really in the early days of Healthy Opportunities, that care management piece became a little bit of a bottleneck. As the sort of conductor of this orchestra, they had a lot of folks joining the band that they'd never met before, to beat that analogy right into the ground. But that meant that sort of the only way into the project is through the care manager. And what we really need to see is layers of support that will help bring people into the program in their times of crisis or opportunities for intervention. And with our providers, it's so hard for our clinical spaces to change workflows in order to bring new resources and opportunities into the process. And so that piece is where the data becomes really important. We know that our providers have a limited amount of time with the individuals that they're supporting with their patients. And if the data is not at their fingertips, then they're not going to be able to be fully engaged with that patient. So the data integration is a really critical part of this. It's not just the way that we treat each other and the way that we access different resources, but it's how we communicate back and forth so that everyone who's engaging with this member really knows them and sees them as a whole person, not just a diagnosis, not just a critical need, but a whole person.
It's a lot to bring together and coordinate. Obviously, if we're able to do that effectively at scale, it would create huge benefits for the patients, members, beneficiaries that are taking advantage of the services. But because you are bringing together lots of different systems with different funding streams, different workflows, different organizational objectives and goals, I'm wondering if you can talk a little bit about who benefits most if we're able to get all of this right.
Yeah, most is probably the hardest way to answer the
Mhm.
question because ideally it's the member that benefits the most, that they have their full needs met, they're able to get well and get back to whatever, fulfills their lives. And so that could be work and family and education and all of those pieces. So that is the goal, is to make sure that that person benefits the most. But that individual is part of a massive system of healthcare and social services in the country. So we actually need the systems to benefit as well, so that the systems are sustainable and the impact on the individual is sustainable and that we can get to more people. So that's sort of bridging the worlds of sort of population and public health along with clinical care and individual level intervention. So when we think about all of the benefits to it, if we get a person to access all of the care that they need, they're going to make the best use of their healthcare options. So somebody who has enough to eat, has a safe place to sleep, is going to be less likely to visit the emergency room. when it's really a hunger issue. They're going to be less likely to show up in a space that is more expensive and less effective than seeing their primary care doctor on a Monday morning. And so we need the system to benefit as well. And so in a good use of social care integration, we would see a reduction in the burden on the most expensive and most difficult healthcare systems, so emergency rooms and hospital systems. We also see an improvement in engagement with a primary care setting. So the vast majority, I think I've heard somewhere between 80 and 90% of all healthcare visits happen in the primary care setting, because that is where the whole person gets to be seen. And so we need to make sure that that is where most people are going to get their early intervention and their direct care and support. Because when those systems, when our primary care spaces, our pediatricians, our family docs are not seeing people at the right time in the right place, they're not able to intervene and they're not able to be financially stable themselves. And then, of course, you bring the payers into this mix. So our government is our biggest payer, Medicare, Medicaid, but then our private insurance, whether it's through the marketplace or a workplace, all of those groups need to see a financial benefit to how this works as well. And those things all come together. So if we have somebody getting the right care and the right intervention at the right time, that intervention is a whole person approach that attends to things like housing, food, transportation, family safety, along with clinical issues like medication, regular screenings, that sort of piece. Then you see those benefits to the system: reduction in emergency room usage, improvement in their primary care access, and less likely to be hospitalized. And we are seeing that in North Carolina. We're in very early days. We're definitely seeing an improvement in the use of healthcare, and we're pretty confident that the financial benefits are beginning.
hmm I'm glad you brought up the financial piece, because a key part of this and why this work sometimes can be so challenging is that you're taking organizations, community-based organizations that have historically been funded through other mechanisms, and now asking them to become Medicaid providers, in essence, which is a big step forward. And I know you've been on that journey in North Carolina, working really closely with organizations to help them navigate that process. And so I'm hoping you could talk a little bit about what that looks like. How do they get through that journey?
Yeah.
What have you learned in helping them that you would advise others to know? Because it is a big transformation.
It is. I think earlier I mentioned that what we want to do as a community care, social care hub, is make sure that our partners get to operate at the top of their expertise. And so that means that we try to take on a lot of the administrative burden and the complexities of working in multiple systems so that our partners can do their work the best. And our community-based organizations are typically mission-driven. They have a goal of reducing hunger or improving access to food or stabilizing transportation and housing. All of these things are the mission-driven work. And it's really important as we come into this Medicaid or other payer space that it doesn't overwhelm the system. It's got to be a part of the solution, not take over the whole organization. And
hmm
so what that means for us is a lot of training and technical assistance. There are also big shifts. So I've spent a lot of years in community-based health, and there has been a movement to stop means testing people. If someone is standing in line at a food bank, they're probably hungry. They're not scamming you for day-old bread.
hmm
And so what can we do to make sure that folks have dignity and support when they reach out for help, that there's no shaming or there's no, do you really need this kind of question? But when you bring in payers and financial accountability related to federal taxpayer dollars and state taxpayer dollars, it's really important to increase the amount of data and the type of data that we're collecting at the community-based organization level. And then that data has also now become personal health information, and it's
hmm
private. It's covered by
Yeah.
HIPAA because they're coming into the system as a clinical patient. And so our job is to work with community agencies to make sure that they have the skills, they have the technology, they have the training to be able to respond effectively while also really staying in their mission work.
hmm
And so, that's been we've spent a lot of time at Impact Health really partnering with groups like Vircho to make sure that they're not spending all day every day on billing. We already
Mhm.
hear that complaint in our care settings that you have to have a whole staff of billing experts to navigate all the payers just so that the docs and the nurse practitioners and all can see their patients. We don't want that to happen to our community-based organizations. So we try to make that lift as light as possible, especially because we started with one payer in Medicaid in North Carolina, but we have every intention of continuing this work and connecting with other payers, both private and government funded. So bringing that expertise and support system in place from the beginning, learning from the clinical side of the house and trying to make it as smooth as possible. That's one of the biggest pieces to transitioning to effectively becoming a Medicaid provider.
Yeah, no, it's a big step, and we've seen across the country organizations struggling with it. And candidly, not all of them have the benefit of working with a partner like Impact Health, who is providing the expertise, the technology, the tools to support some of these challenges. So, just a question: if you were speaking with a CBO leader from across the country who's just beginning this journey, what's the first thing that you would tell them to think about, to focus on, to prioritize?
Find good partners. Don't go it alone.
Mhm.
We're seeing a lot of folks who are really interested. This is truly a national movement, what we're trying to do here in North Carolina, and it's in states all over the country. Don't build from scratch any pieces of this. Connect with folks who are a little bit further down the path with you and who have already made the mistakes and stumbled, and learn from each other. So I think that's the first one, is reach out and connect with people who are doing this work. Build your network of experts and trusted partners. And then the second piece, I was just talking with some of my colleagues about this morning. North Carolina is in a really difficult position right now as we wait for the state to pass a budget so we can get back to work on the Healthy Opportunities pilot. But in the meantime, as our community-based organizations get involved in this work, it's so important to stay grounded in the relationships that you already have. So clinical integration is just part of a whole. The funds that we can draw down from clinical dollars will not solve the full problem of hunger in a community. It will not solve the full problem of housing access. And so, how do we make sure that that stays part of a whole? Because historically, government funding has been very predictable, very reliable, but right now we're definitely in a phase of major transition, major changes to institutions in this country. And so things are a little less predictable. And so that's why it's important to stay in relationship with those other funders and partners that you're working with, and really merge this into your work. Don't replace your work with it. It is exciting and it is changing lives and it is getting great outcomes with real data, but it can't be the whole story in a CBO. It's got to be part of the whole.
Mhm. No, that's such a good point, and particularly relevant given what we're seeing happen right now in that kind of macro environment, and particularly with what's going on in North Carolina, as well as the government shutdown in DC. And so lots of complexity to navigate there. One big part of your story in North Carolina has really been about getting the data integration piece right. That's truly hard work when you're dealing with different data sets, different organizations, and that data liberation, integration, and creating something that's actionable for all of the different partners is really difficult. We've seen a lot of organizations struggle with that. So I'm curious, when you think about the journey that you've been on in North Carolina to get that data integration piece sorted out, what did you learn? What would you advise others to think about? And how would you recommend they approach tackling that piece of the puzzle?
That has been a huge, from day one, part of our journey to try and figure this out. In public health, you're lucky to have 2-year-old data when you start to make decisions and move forward. And with this approach, we have an opportunity to look at almost real-time data to make data-driven decisions to improve the program while we're in it. We don't have to wait until the end to see how it went, and to really sort of invest the program in the places where we think it can have the greatest impact. That's been really tough. In North Carolina, we have learned so much in 3 years. And one of those is that the way that the network leads were originally sent up was intended to keep us hyper focused on the community based organizations and really support them. But we've learned that the best way to support them is for the network lead or the community-based hub or whatever the right word for us is right now, is to make sure that we have access to layered data and that we can feed that into community to make the best use of the resources that we have. So for example, we had an estimate of about how many eligible members we could expect in our region, and we had those head counts by county. If you've ever lived in a rural community, the county line is almost meaningless. If you
Hmm.
live on a county line, you may work in another county and see your doctor in another county and get your groceries in even another county. So the county lines are not super helpful when you're planning. We need to know where those members live, why we think they're eligible. Are we looking at metabolic disorders? Are we looking at folks who have pinged for potential domestic violence in their household? What makes them eligible for this program? How can we better connect? So that's on the planning side. We really have worked with the state and with our payers to try and get better access to data about potential eligibility for the program. We're not quite there yet, but we will be soon. And we, again, could not do that without partnership from Vircho, which helps us draw together a huge amount of data from really disparate locations, from public data sets to private real-time referral data to private medical information.
Hmm.
Um, on the other side of it, in order to get true engagement from the clinical side, because our clinical partners are used to having real-time data, are used to having a lot of information at their fingertips to make really good decisions for their patients and with their patients in order to get them to optimal health. So we need to make sure that the social data that they have access to is starting to meet that standard. So they know my member gets or my patient gets a delivery every Friday of fruit and vegetable, or they are currently getting medically tailored meals so that I know that they're getting the nutrient dense food that they need to be responsive to their metabolic disorder. We need to be able to pull that data in both directions and really make good plans and then make sure that our clinicians have data to make good decisions in partnership with their patients. And so we weren't really seeing that happen in the way we would want it to through just the Healthy Opportunities pilot. So in partnership with Vircho, Innovator, and some other partners in our region, we actually launched a small clinically integrated network under our hub. So
Hmm.
now within our community care network, we have both the clinical side and a small group. I'm sorry, we have a small group of the clinical side and our group of agencies in the community that are under one umbrella and really talking to each other. And the way that we've changed that model takes the data backbone and human connection.
Hmm.
And so we take that real time data and we have our care management and care navigation staff, and then they are in real communication with our clinical partners to help them see where the data is and how they can connect to it. So those pieces all sort of come together to make the best possible use of data. It's an ever-changing field, and as we bring in more data sets and more information, we can better invest the dollars that we have so that we have also got the most efficient use of the funds that we have to make sure that we're investing it in the places where folks will have the best outcomes. And that's a real paradigm shift as well for those of us who have predominantly lived in the community care space. It's often a volume game. We know, for example, in North Carolina, 1 in 4 adults, 1 in 5 adults, and 1 in 4 children are food insecure. They don't know how much or where their next meal is going to come from. Causes a huge amount of stress on the household. And so ultimately, our goal is to get good food to as many people as possible. Um, that sometimes makes it really hard to get to the folks who could potentially benefit from it the most.
Hmm.
And when we get into this clinical integration space, we have the opportunity to be very targeted and very intentional in how we deploy those resources so that we see both the community impact and the individual level clinical impact, which, as a community-based organization, it is so hard to get that kind of data.
Hmm.
And so, again, that's why it becomes a blend of all of the pieces that our community-based organizations can deliver against and not the whole picture. So we have to balance those intentions of the clinical work that deals more with support for the individual and our social work that deals more broadly with community strength. And when we blend those two things together, we just get really incredible outcomes. And we can't do that without a really strong data infrastructure.
Yeah, I've seen that what happens in communities when you don't have that, and it's so difficult to stitch together all of those pieces. And it really doesn't work for either side of the equation. What we hear very often from providers is, they don't want to make a referral if the service isn't going to be delivered. That's a bad experience for their patient. They want to know if the service is delivered so that they can have a conversation with that patient about it the next time they come in. So
Yeah.
if the providers are blind to what's happening, it's really difficult for them to have confidence that they should be focusing on that during those clinical encounters.
Mhm.
And then on the other side, if you are the CBO and you're just receiving, blanket referrals without knowing, is this person, in my service area? Do they qualify for the services that I provide? Are they the right fit for the kinds of services that our organization delivers? It's difficult for them as well, especially when they're often navigating what can be pretty severe capacity constraints. And so trying to do the best they can with the resources that they have and the team that they have available. And so the idea that technology could solve both of those problems by filling both the communication gaps, but also making the data more actionable. So we're making better decisions on both sides about who we refer,
Yes.
where we refer them to, and then how we deliver those services so that we can, to your point, make the best use of the dollars that we have. I think that's going to be key. And data integration is going to be at the core of all of that.
That's exactly right. That's the other piece that our community-based organizations often struggle with is having access to their own data.
Hmm.
A lot of times the purpose of data collection at the community level may be in order to report back to grant makers. And so each funder wants a different type of report on what is happening and how it's happening and what the quality looks like. And it is a heavy burden on our
Hmm.
community-based organizations. And so when we're able to partner with them to have dashboards where they can, with a glance, see some of the things that they're going to need to report out on, like the number of families served or the number of individuals receiving one of their services or, any number of things that their funders might care about. It really gives them more control over how they are participating in certain interventions, how they're reporting about it, how they're telling their own story. I can't tell you the number of times over the last 3 years that we've had a request from one of our community partners asking for their own data. And that shouldn't have to happen. They should be able to tap in and get their own information. And technically, all of these different platforms, you can export data, but it doesn't mean it's useful in the moment. And so that's one of the other focus areas of our data integration is to make it useful. So like you said, for a physician relationship, it's really important that the provider can trust that the referral that has been sent has been fulfilled and then see what's happened so that they don't break trust with their own members. And that also really matters to our clinical partners that when they receive someone, that they're able to manage their own workflows and their own capacity and that they feel supported in saying, yes, we've hit our capacity for now, so we're not going to be able to take referrals until we get a few folks moved up and out. Um, but when they're flying blind, and we saw this happen in the early days before we really had access to some of this data, where a small community-based organization may be overwhelmed with referrals, and that hurts everybody in the system.
Hmm. Yeah, it's so interesting. The data that you have access to, the dashboards, the reports that you can see around things like the time to fulfillment, right? And so the visibility to understand which organizations are able to complete that service quickly, which ones are not, and then being able to dig in to understand the why behind that. Is it just that they're at capacity right now? Is there some other issue going on in the organization? How can you help them, right, if they are
Yep.
struggling? I think that's key because I would imagine that before technology and tools like this existed, you as the network lead are sitting there and you're getting different disparate information
Yeah.
from all of the organizations that you're working with. You don't have some way to aggregate it into something actionable in the flow of doing the work. You might be able to look back, quarters later and see, oh,
Yeah.
something was going on there. But to have that information at your fingertips and be able to use it in real time to make better decisions, I think will prove to be a game changer for this space. And it's something that
Yeah.
we've had on the clinical side for a long time. So the social care
Yes.
world, I think, will benefit from bringing some of those capabilities into this space as well.
Yeah.
One example of that that is a powerful story that you've shared before, but it really sticks with me, is what happened when Hurricane Helene hit. and the system that you had built, the network, all of the both the human relationships and the trust, but all of the data as well was really tested. And so I would love for you to share a little bit more about what happens when there are these external disruptions that can really put pressure on a system, even if it's well functioning before that.
Yeah, it's an interesting story to sort of talk about how our data infrastructure was so important to us at a time when we had no power, internet, phones
Yes.
for
Yeah.
a stretch, but it was a critical part of it. But when I talk about our network this way all the time, is that, while it relies on contracts and legal relationships between the community organizations and our hub, that is just the start of it. So it's really been about bridging relationships between and among agencies that have historically had to compete for funding or service delivery, and really building trust and openness between all of these organizations and ourselves. And so we've just passed the 1 year anniversary of Hurricane Helene, which it still doesn't quite seem real to me how the level of devastation that our region faced. You can see it from shots from space. That still blows my mind that you can watch the track of the hurricane. And then Asheville and some of the surrounding communities faced a second wave of rising water, so incredible flooding, and it just took out almost all of our infrastructure. But we had been working with these community-based organizations for 2 or 3 years, and many of them had been operating in the region for generations. And so the relationships that we had built, undergirded by the technology and data exchange of the Healthy Opportunities pilot, allowed us to really be a resilient set of agencies.
Hmm.
And it showed up in some really unexpected ways. So, for example, our hub was able to receive from a couple of funders about almost $7 million in hurricane recovery and response. And because we were already in legal relationship with over 60 agencies in the region, within days we were able to push out sustaining funds to help people continue to pay their staff and procure food and shelter, and really support the region, even without any kind of phone or internet or computer access. And that allowed our agencies to stay staffed. There are a lot of examples of devastating instances, like in Hurricane Katrina, where the local agencies didn't have funds to keep their people staffed, and they had huge turnover in their social safety net in the weeks and months following the hurricane, which is really unsustainable when you're in a recovery space. So we were able to distribute funds really quickly through other agencies. But the other piece was that our community-based organizations are deeply committed to the service and the provisions and the relationships that they have with the members. And so that showed up in a couple of ways. One is that they were already checking on people to make sure that they were okay. A big part of those first days of the hurricane was wellness checks. Who survived this? Who was trapped? Who needed to be rescued? And our community-based organizations were a part of that movement because they knew their people and they knew where they were and they knew how to get to them. And so we were able to confirm that people had survived and were ready for support or ready to get out of their spaces. But two, they were able to continue providing most of the services that were related to healthy opportunities. One of the pieces of that is that just like any other clinical care you might get, you have to get approval for it. And your insurance company has to agree to pay for the service that you are seeking out. And we had folks that their approvals were lapsing during that time, and there was no way to seek approvals for those services. But the community-based organizations were so committed, they kept delivering services. They didn't
Hmm.
know if they would be compensated for them, but that is their mission. And that is why, again, it's so important to work with these agencies that have deep commitment to their missions. And in partnership with Unite Us, Vircho, and Department of Health and Human Services in North Carolina, we were able to get some waivers, get some flexibility, and ultimately bring almost $500,000 in reimbursements during those weeks following the hurricane that otherwise would have been lost. And if we didn't have those relationships and that data infrastructure connected, I'm sure we still would have found some ways to provide support, but we were able to do it in a way that was unimpeachable with respect to things like audits and state accountability and taxpayer accountability because we had the data and we could really hold it. So members were seen, they were supported, and our community-based organizations were kept intact so that they could keep doing the work that they do in order to serve this community because this recovery is going to be 10 years long and we can't do it without this network.
Yeah. No, it's a really powerful reminder that, the work that is going on to build social care hubs, the networks, the delivery system to support it, the data and technology infrastructure, all of that, I think when we think of it, we often think of it as a long-term game, right? We're making investments in communities and populations, in organizations that we hope will pay off in the long term. But it's just a powerful reminder that there are like things that happen unexpectedly, and building that will also create stronger communities for crisis response as well, right? And
Yes.
disaster recovery. And so I think it's important to remember that there's a lot of different benefits that come from this work, and that it's a powerful reminder of why we need to have the systems in place to enable it. Because when you do get those seismic disruptions, you want to be prepared. Just one question though, reflecting back on it now that it has been a year, is there anything that you think you would do differently, based on what the ultimate experience was and the results that you saw from the work that you and your team did?
Do you mean relative to the hurricane or to
Yeah,
the
just as you think
overall?
about, because I'm sure in the moment, right, you're just responding so
Yeah.
quickly and trying to come up with a plan. So now, with the benefit of a year to reflect
Yeah.
on it, is there anything you would say you would do differently, or that you would encourage others that find
Yeah.
themselves in the unfortunate position of having to respond to something like that, that they should think about in the moment?
Yeah, the thing that hits me over and over again is that everybody in this hub was both a survivor and a first responder. And
Hmm.
so there wasn't a lot of space to process it. And
Hmm.
so things that I would encourage other groups like this to think about are one, to think about how you will care for your members who are on the front lines doing this work in the wake of the hurricane or the disaster that hits the community, so that you can care for them in the aftermath as well. So we've done a lot of work with resilience building and trauma response and really just trying to support people who went to work right away and sort of with no regard for their own experiences. They just helped the folks around them. So really thinking about how you're going to prepare for that support. I think we would also say we didn't plan this, but we're lucky to have it, was to have a lot of partners at a lot of levels who were all over the state, the region, and the country. Because when we were in sort of a complete blackout, we had partners in New York and Raleigh and South Carolina and other places that we could depend on because we already had trusting relationships with them to help us navigate through this. And I would be very intentional about making sure that you have loops and layers of trusted partners should something happen in any one of those areas. Because I also think a little bit about some of the other sort of disasters, man-made or natural, that have happened, and some of our key partners would have been unable to be a part of our work. So what does it look like if something happens to one of our other partners, how we work together? So I think it's really important to have a good network that is bigger than you, bigger than
Hmm.
what you're doing, or has multiple responsibilities and perspectives. And that's for a million reasons. It's not just the disaster response, but always having somebody who can, hold up the marble and see it from a different angle and support. And I don't think our recovery from hurricane would have been as smooth as it's been without partners like Vircho in our corner, ready to respond and already knowing what we do so that they could be a part of how we keep doing it and how we get back to it after the fact.
Yeah, no, it's a really important reminder, because sometimes we get focused on, what's right in front of
Yep.
us. But to pick up our heads from time to time and look around and reach out
Yeah.
to those collaborators in other communities, to benefit both in terms of the day-to-day work, because this is hard work, that you all are
Mhm.
doing. And a lot of it is carving a new path forward. And so to benefit from that experience, but then also to have those partnerships and relationships to lean on
Yeah,
when you need it or when they need it, is critical.
exactly.
So, um, Laura, you've been so generous with your time. So thank you. Really appreciate all of the insights and expertise that you've shared. Just a final question as we wrap up, big picture, as you think about the journey you've been on, everything that you've learned in your
Mm.
work in North Carolina and everything you've seen that's going on across the rest of the country in this space right now, what would you want to be the one thing that you share with folks about social care hubs, the role that they play in this, and how you would advise them to be thinking about their strategies going forward?
I think probably to oversimplify it, I would
Mhm.
say that you have to be connected beyond your own individual focus. You have to, as a hub, be in relationship with organizations that are bigger than social care integration and also care deeply about it. We're in this really difficult time here in North Carolina where the bulk of our funding is on hold until our state gets our budget passed. But we have other partners that are ready to work with us, other payers, to be able to continue doing this work. And so as you go into this, I think the idea is to have a broad approach to a very specific implementation. So
Mhm.
again, thinking about all of these overlapping groups that we partner with. So from the community care hub perspective, working with people who care about what you do and also do other things.
Mhm.
And same for our community partners, for those organizations that want to be linked into a community care hub. Don't let go of the rest of your mission and vision and partnerships, because we all have to share parts and pieces of this. And again, if you have a hub that is focused on the administration, the data, the compliance, the support, then that allows you as a community organization to maintain your focus on the delivery and make this a part of the whole.
Yep. Well said. Thank you, Lori. Appreciate all of your insights, expertise, and your time this morning. More so, thank you for all the work that you're doing in North Carolina and beyond. It's truly important, and we appreciate it. So, thank you.
Thank you.